Greetings. So let's talk about magnesium in this video. Um, how is magnesium distributed through the body? Uh, 49% of magnesium is in the bones, 50% of magnesium is in the intracellular space, and that leaves 50 plus 49 is 99%. So 1% of magnesium is actually in the extracellular space. Okay, and out of this 1%, 0.7% or 70% of extracellular magnesium is unbound and active. And that means metabolically active and is used for cellular processes. And again, this would make more sense. So remember, calcium, you would have the ionized calcium. So this unbound active magnesium, which is 0.7% of body's total magnesium, or 70% of extracellular magnesium, is equivalent to that ionized magnesium. You have 0.2% or 20% of that extracellular magnesium bound to albumin. So remember when we did calcium, we talked about that non-diffusible one. And then of course 0.1% or 10% of the extracellular magnesium is bound to anions and gives us salt. So it's sort of equivalent to our diffusible uh, bound calcium. So that's sort of how magnesium is distributed through our body. Regulation of magnesium. So here's the fun part. Unlike calcium, sodium, and a lot of other electrolytes, there is no hormone regulation that we know of for magnesium. So in other words, it's less stuff for us to learn for magnesium. Um, the easiest way to understand magnesium and its regulation is what I've shared here. So you have magnesium in your blood. So this is blood. And essentially the biggest regulator is the excretor of the magnesium, which is kidneys. And so what happens again in the kidneys is this is blood coming into a nephron, and then you have the nephron here, and then blood comes in, and then it filters uh, the uh, the filtrate, which then goes through tubules, and then stuff gets reabsorbed uh, by the blood back. So essentially, first a bunch of magnesium is filtered, and then it interfaces with our blood supply. And if there's a lot of magnesium in the blood, um, and there is magnesium here in the kidneys, so what happens? So if we were to kind of blow it up a little bit more, so this would be the nephron, and this would be the blood supply. And then this is the tubule, so this is where mag got filtered out. So if you have very high magnesium levels here, the magnesium um, does not passively diffuse into the blood. Why is that? Because remember when we talked about diffusion, what's that? Diffusion is when something goes from high concentration to low concentration. So if the blood magnesium is very high, the magnesium in the urine filtrate or glomerular filtrate will, there wouldn't be a diffusion gradient, or it would be less likely to flow back into blood. Why? Because the levels are very, very high. So again, this is the way to think about it. I have magnesium in my filtrate and I have very high magnesium in my blood. So this is my blood and this is my tubules in my nephron. So again, that magnesium won't be reabsorbed, and we would pee out that magnesium. Okay. If I have low magnesium on this side, right, what would happen? Now I got a lot of magnesium in my tubules, in my nephron, and it's more likely that it would be reabsorbed back into my blood. So that's sort of the mechanism that the kidney apparatus and the blood have to excrete magnesium. And that's how magnesium is regulated by excretion. Again, so if we consume magnesium by passive diffusion, magnesium goes into our blood. Again, passive diffusion, it's the same thing. If it's the GI tract and this is the blood supply, right? If I consume lots and lots of mag, however, my blood supply has lots and lots of mag, well, uh, remember the concentration of mag if in the blood is high, uh, the GI tract will not passively diffuse magnesium into the blood, right? Again, if there's low magnesium, now diffusion through diffusion you would have GI magnesium, which is a lot, go into blood magnesium, which is low, right? So passively diffuse into the blood. And again, there's regulation with bones as well. As bones turn over, that magnesium goes into the blood. So the big uh, issue or the big change with magnesium is no hormonal regulation, and it's actually through diffusion where the blood levels of magnesium are controlled, whether it be increasing or decreasing. Okay? So now that we understand the regulation and the distribution of magnesium, let's talk about too little magnesium in the blood, or low magnesium emia blood. Again, mag levels, anything less than 1.4 milliequivalents per liter is considered low magnesium. So if you remember low potassium and low calcium lectures, so if you're not sure, go back to those lectures. We talked about whenever you see low potassium, keep your eye on the magnesium. And whenever you see low calcium, keep your eye on the mag. Because a lot of times your mag is concurrently low. And so I don't know if you remember that. If you don't, watch those videos again. So the symptoms, the way to remember magnesium symptoms are symptoms that are associated with low potassium and low calcium. Aha, this is easy, right? Because if you remember those, work for the magnesium is done. So low potassium, what are some of the things? So remember EKG. K is EKG, right? So that T is now depressed. Remember P, QRS, T, right? Now this T becomes depressed. And then you start to get another wave after T, which is a U wave, right? So those were very specific symptoms for hypokalemia. What about low calcium? Remember you had that perioral tingling, the facial nerve tap, which is Jawot-Tex sign, and then carpopedal spasms when you inflate the blood pressure, which was Trousseau sign, right? So these are very specific symptoms for low calcium. So this is what you're going to see with low magnesium, especially if there's a concurrent abnormality of potassium and calcium. Now, if someone, especially this is true for the test, if someone has to isolate just magnesium and magnesium, low levels of magnesium, what they give you is a EKG manifestation which tends to be very, very specific for magnesium, and that's Torsades de Pointes. Okay, so let's take a look at it. Again, this is high yield as well, which is why I'm sharing this with you. Remember, you have P, QRS, and T, right? So P, QRS, and then T. So this is your normal waveform. Well, there's a rhythm called ventricular tachycardia. And essentially you have broad QRS, right? And then you have another broad QRS, and then you have another broad QRS. So essentially it goes something like this, right? That's what you get to see. It is a life-threatening rhythm. It's a very serious rhythm. So again, if you see, it's kind of pointed at the bottom, okay? This waveform that I've drawn, it's more rounded on the top, okay? More rounded on the top, okay? So this is ventricular tachycardia, and all the bad waveforms look the same. They're pointed at the bottom and rounded at the top. So this is the morphology, or the way the QRS looks is one type, monomorphic, right? Because it's rounded on the top and sharp at the bottom. Rounded at the top, sharp at the bottom. Rounded at the top, sharp at the bottom. Well, there could be another kind of ventricular tachycardia where so if it's rounded on the top, sharp at the bottom, rounded at the top, sharp at the bottom, and then sharp at the top, rounded at the bottom, sharp at the top, rounded at the bottom. So you see here the waveform looks different because again, you see here how it looks different? It was rounded on the top and now it's rounded at the bottom and sharp on the top. So again, this is a morphology of QRS which is bimorphic. Okay, so essentially when you have QRS where the QRS looks different and sometimes it looks one way, sometimes it looks another way, that's called polymorphic. So ventricular tachycardia, where QRS looks different, is called polymorphic ventricular tachycardia. Okay, and that's got a special name. It's called torsades de pointes, and that is pathognomonic for low magnesium levels. So again, symptoms that are, you know, you see a lot with magnesium levels low are symptoms of potassium and calcium. But if somebody gives you a waveform which looks like torsades de pointes or has polymorphic VTAC, look for the calcium levels. On the test, it's very high yield. Okay, so these are symptoms of low magnesium. So what's the way to think through low magnesium levels? So remember, you had the GI, the kidney, right, and the bones. So so if somebody has low magnesium, is it because they're not taking in enough magnesium? And those are people that, let's say, are drinking a lot of alcohol, or if there's anorexia, right? So that's some of the things that you associate when you're looking at not enough intake. What about if they have a lot of diarrhea? Well, they're losing a lot, right? And they lose a lot of magnesium, right? Good, good. And then you also have kidneys. So what if somebody is taking diuretics, right? So that's going to cause renal loss, right? And cause low magnesium. And that's what you look at: low intake, excessive loss, and renal loss. Okay? How do you approach a patient? Does the patient have symptoms? So remember, either low K symptoms, low calcium symptoms, or torsades. And that would include arrhythmias, right? Yes. And low potassium, okay? Or low potassium. So if the patient has any of the symptoms, including arrhythmias, or they have low potassium along with low magnesium, which is what we are chasing, then I have an unstable patient. Unstable low mag. Okay? If the patient doesn't have any symptoms, then it's a stable low mag patient. Okay? Now, The next thing with magnesium is to look at the kidneys, because kidneys are very, very, very important excretors. And if the kidney is shot, that means whatever mag I'm going to give them, it's not going to go anywhere. It's going to remain in the system. So if I replace it and replace it aggressively, now I have a situation where the hypomagnesemia would turn into hypermagnesemia. Why? Because it's going to be excreted. So whenever we are replacing magnesium, whenever we have low magnesium, we got to replace it. But before we replace it, we've got to ask ourselves, does the patient have kidney disease? So let's say they do. What do we do? Well, most of the times it's dialysis. Okay? Most of the times it's dialysis. If the patient does not have kidney disease, one may consider IV magnesium 1 to 2 grams. Again, in literature, you'll find if they have mild chronic renal failure, while the provider can consider careful administration of IV mag, but you got to keep a very, very close eye on how they're excreting magnesium and their serum magnesium levels. Okay, so that's with the unstable. It's dialysis if they have kidney disease, or you give them IV because it's unstable. For the stable, if they have kidney disease, again, it's dialysis because the kidneys are shot. If it's mild, one can give by mouth mag. If no kidney disease, then it's by mouth magnesium. And here's the fun part: it's stable. There's no symptoms, so we don't have to go the IV route. Okay. And again, if there's concurrent potassium and calcium, we got to treat the potassium and calcium as we have, in our videos before where we've discussed low potassium and low calcium. Okay, so that is low magnesium. Now, let's talk about high magnesium. So, high magnesium is hyper, too much, magnesi, that's magnesium, emia, in blood, or magnesium greater than 2.1 milliequivalent per liter. Okay. So what are the symptoms? Neuromuscular relaxation. Okay, neuromuscular relaxation. So low reflexes, low respiratory rate, muscle weakness, so it's actually low muscle tone or muscle weakness, and drowsiness. This is a drug that is very so mag sulfate is used very commonly to prevent preterm labor. And so when we are assessing these patients, these pregnant patients, while we are giving them magnesium sulfate, guess what we check for? Their reflexes, their mental status, their respiratory rate. Okay, so this is a relaxer, and that's why it relaxes the uterus. Okay, so what causes it? Again, if you're taking in too much, for example, IV infusion in a patient with preterm labor, if we are not excreting it enough, and the biggest reason is renal failure. Okay, and then last but not the least, so remember, where do we have 50% of magnesium? It's inside the cell. And then 1% is outside, right? And then 49% of it is in the bones. Now, what if there's something which caused the cell to lyse? All that magnesium on the inside will come outside. If there's a lot of cells that lyse, for example, with tumor lysis syndrome, all that mag is going to come out and is going to flood the blood or the extracellular space. So those are 3 reasons for high magnesium. So treatment. Does the patient have symptoms? What are the symptoms? Symptoms of neuromuscular relaxation. The patient does. You have high magnesium and the patient has symptoms. This is what? This is an unstable hypermagnesemia. What you gonna do? What you gonna do? So one can give calcium gluconate, which will act as an antagonist of high magnesium. And this is just a temporary fix, okay? So that the symptoms of the patient, because of high magnesium levels, are not life-threatening, okay? But essentially, uh, so again, if they are unstable, we give them calcium gluconate just to stabilize the patient. But for both patients, whether they have symptoms or not, when it comes to hypermagnesemia, um, we got to see how their kidneys are. Remember, because kidneys are very tight regulators of magnesium. What if the kidneys are shot and this patient has very high magnesium? For example, in renal failure. Eh, that magnesium is not coming out of the body. And the only way I can get it out is through dialysis. And that's again for the patient that's end-stage renal disease where the kidney is shot. Okay. If the patient has mild renal function abnormality or they have mild decrease in renal function, one may consider giving IV fluids or IV normal saline with Lasix. Lasix is a diuretic, and it's gonna the patient is gonna, because the kidneys are still working. Again, that Lasix is gonna act on the kidneys and increase the excretion of that extra magnesium. Again, because there's mild impairment of kidneys. If the kidneys are normal, the biggest thing one can do is stop the cause of increased magnesium. If one can stop the cause of increased magnesium, the kidneys will actually take over and take care of the magnesium and normalize the magnesium. And so that's it. That is what one does for the magnesium. Let's do a quick recap. What did we talk about in this video? We first talked about magnesium and how it's distributed. And it's most in the intracellular fluid, 1% in the extracellular space, and then 49% in the bones. We talked about regulation with kidneys being the biggest one. There's no hormonal regulation, and the movement of magnesium is through passive distribution. You have GI tract that diffuses magnesium into the blood, and then you have bones that go back and forth with the turnover. Okay, yeah, so that's how magnesium works, right? That's how magnesium is regulated. Then we talked about low mag levels, and we started with symptoms. So symptoms of low potassium, low calcium, and torsades, which is very specific for mag and high yield for mag when we are talking about hypomagnesemia. So again, the causes, either it's increased intake or decreased intake or decreased absorption, excessive loss, or excessive loss through the kidneys. So that's sort of when you have low mag. Decision tree. If the patient is symptomatic with low magnesium, that's an unstable patient. That's an unstable low mag patient. However, before IV replacing the mag, I want to see if the patient has kidney disease. Because if they do, I'm going to run into the other problem of hypermagnesemic the patient. So again, if they have kidney disease, we consider dialysis. If there's no kidney disease and the kidneys are working good, we may supplement the patient with IV magnesium. If the patient doesn't have any symptoms, then it's by mouth magnesium unless the patient has kidney disease, in which case, again, it's dialysis. Okay? And then again, replace calcium and potassium because, as indicated, because whenever we see low calcium and low potassium, we keep our eye on low magnesium. Whenever we see low magnesium, we keep our eye on low potassium and low calcium. And we got to replace those, and that replacement and decision tree goes into the videos associated with calcium and potassium. So make sure you review those. Lastly, we look at increased magnesium, and the symptoms included low reflexes, low respirate, and drowsiness. And the causes include, again, high intake, low excretion because of kidneys, and then the mag coming out of the intracellular space. into extracellular space. Treatment, again, if the patient has symptoms, give them clear calcium gluconate to stabilize the patient. And then if the patient's kidneys are normal, just stop the extra source of magnesium, um, and the mag levels will just go back to normal very quickly. If there is kidney disease, if the kidneys are completely shot, then it's dialysis because that mag can't come out. If there is mild dysfunction of kidneys, that means kidneys are still working. One may have to push things along, and the way to push them along is to encourage the functional part of the kidneys to excrete more magnesium, and we do that by giving them fluids and giving them Lasix, which is a diuretic, which is going to cause that mag to excrete out and the levels to come back.